I'm just going to verify that there is a quorum. And we may be one short.
I've got one short. Yeah.
Yep. And Craig, does my camera have to be on?
No, because you're staff, but the board members have to have their cameras on.
Perfect. That's great news because I'm trying to take minutes, live stream, and have the meeting on my laptop. So that's great.
But I'm hoping that we get somebody else in the next minute or so.
Yeah, I do know Mayor Adams will not be here. Walton also will not be here.
I mean, we can always meet. We just can't make any decisions. Let's see. Warsaw. Sounds good. Does anybody have Pendleton County Ambulance or Pendleton Water that they could contact? Or Crescent Villa Fire Authority? Um,
Uh, Those are the three who had not responded at this time.
What do we have that needs to be approved, Craig? Anything?
well, other than the agenda and the minutes, there is a MedBin contract amendment. That was a part of the backup material. Hey, Jeff.
I'm Warsaw's gonna get on.
Yeah, Crescent Villa's out because they're working a accident on the interstate.
Warsaw's getting on. It's just gonna take just a second. All right, we do have a quorum with April joining us.
All right. Okay, great.
Are you able to turn your camera on, April?
Awesome. All right, thanks everybody for joining us. I really appreciate it. With that, we now have quorum, so I will go ahead and call this meeting to order at 9:10. Just to follow the agenda, Madam Secretary, do we have a quorum?
Yes, we do have a quorum with at least 9 present.
Okay, great. Next item on the agenda is the approval of the agenda. I will accept that motion.
So moved.
Harry, is there a second?
I'll second.
A second, Paul. All right, all in favor, please signify by saying aye. Aye.
Aye.
Aye.
Aye.
Any opposed? Okay, great. Next item on the agenda is the approval of the minutes. That was in your packet. If there's any questions or changes. Hearing none, I will entertain a motion to accept the minutes.
So moved.
Harry,
A second.
Linda, thank you. All in favor, please signify by saying aye.
Aye.
Aye. Any opposed? Okay, great, thank you. Next is the financial report.
Okay, I'm gonna go ahead and share my screen. I think, Avery, you gotta let me have that ability.
Should be good now.
All right, thank you. Are you seeing my screen yet?
No.
Okay, hang on. I had it. I was all ready to go, I promise. Okay, how's that?
Nope.
No? Oh, okay, one more button.
There it is.
Now, there you go.
There you
How's
go.
that? Sorry about that. Okay, so this is a financial report that represents all of the last plan year. So from July of 25 through June of 26. And before I get into the details, I just wanted to make a couple of comments. So you finished the year with a lot of high claimant activity. In fact, you had over $1 million in claims in June. So you went out with a bang. You actually had over $1 million more in high claimant activity compared to last year, as you'll see when we get into the MedBen reporting. But the good news is you got $1.3 million back from stop loss. And of the 25 high claimants that are on your plan, 21 of them have improving risk profiles, which you'll also see when we get into the details of the report. So with that, I'll walk you through the year-end numbers. So in terms of your in-network medical claims, you had $4.5 million, and out-of-network medical claims were about 1.1 million. Your pharmacy claims ended up at about $932,000. Specialty drug HRA claims of 141,000. Your total fixed costs, so this would be your premiums that you pay for your stop loss and the administrative fees to MedBen and the Jefferson Health Plan fees, about 1.5 million. So your total plan costs were about, before reimbursements, were about 8.1 million. You collected premiums, or JHP collected premiums, I should say, of $6.4 million. And so prior to stop loss reimbursements, the net plan costs were negative 1.7 million. But when you factor in the $1.3 million in stop loss reimbursements, the net plan cost is negative 415,000, to which we add the interest that you earned through JHP, which was about 1,300, subtract the PCORI fees of about 1,600, and then there was the transfer from the legacy reserve of 181,000. So the approximate balance in your JHP account as of the end of June 30th is about negative 234,000. And then you do still have the legacy reserve. And as of the end of the last plan year that ended in June of 2025, you had 2.1 million in that account, to which we add $34,344 in buy-in fees from some of the newer participating entities. And we subtract the fees and the insurance, and that was about 24,000. Subtract the transfer into the JHP reserve account of 181,000, and add in interest that the legacy reserve earned, and that's about 39,000. So the legacy reserve is sitting at approximately 1.9 million. And pharmacy rebates are included in the claims totals. They get subtracted off of the check runs before they come out of the bank account. So that's the year-end financial report. Any questions?
No, you said 21 of the 25 are projected to be lower than?
Yes, and we'll see those details in a minute. You actually had one claimant that had over $800,000 in claims. I think that might be a record for the plan. I didn't go all the way back to the beginning, the inception of the plan back in 2014, but you had some very, very high claimant activity. But a lot of it was on the one claimant, which can be a good thing in terms of stop loss reimbursements, because if you have 4 or 5 high claimants who are just over the specific deductible, sometimes that's more impactful to the plan than having one claimant who has a ton of claims, because you get more stop loss reimbursements when it's just the one. But you did have several others besides that one, but that was the most noteworthy. And we'll see all those details in the high claimant report.
Okay.
Lisa, sorry. So on the form here, it indicates there's the specific stop loss, and then there's 0 for the aggregate. But
Yes.
is my understanding like that the one bucket was a specific would be the 85,000, correct?
Yes.
And then would spill over into the aggregate of 150. So is there a difference there, or is that just it all got accumulated under the specific?
Well, in our industry, we tend to use the same terms to mean different things, and that's the case here. So you do have aggregate stop loss coverage, and JHP is working on a better methodology for showing how you're running up against your aggregate, but we did check with them to see if you were due any money back under your aggregate stop loss, which is the second kind of stop loss coverage that the plan has in addition to specific. So just to kind of refresh everybody's memory and for the benefit of newer members, the plan has 2 kinds of stop loss coverage. One is specific, and that is coverage for any claims that the plan pays for an individual over $85,000. And then, and it's a little more complicated than that, but that's basically what specific coverage is for your plan. And then there's aggregate coverage, which is protection for all the claims that the plan is paying underneath the $85,000 specific deductible. And then when I said there were two terms that mean that are the same but mean different things, we also have an aggregating specific deductible of $150,000 that is one-time liability that the plan has to satisfy before any money comes back from the stop-loss carrier. And that is $150,000 for the whole plan. So anybody who goes over $85,000 can satisfy that $150,000 specific deductible. So you satisfied that. So we paid out that whole $150,000 aggregating specific deductible. And that's you, if you hadn't, you wouldn't be getting any money back under the specific stop loss. So this aggregate stop loss is not that $150,000 aggregating specific. It's actually what we call aggregate stop loss coverage.
Okay.
Does that make sense? I know it's a lot.
It does. I appreciate you clearing that up. Yeah.
Sure.
Thank you.
You're welcome.
Any other questions on the financials? I'm sure we'll have a chance to kind of go over this before we get the renewal from JHP early next year.
Yes, and I mean your rates for this upcoming year are locked in. Nothing's going to change until next July. So
Right.
A lot
Right,
can happen
right,
between now and then.
Right, but we go through that renewal process starting in like March, and we
Yeah,
so
we should have the renewal March or April next year.
Yeah, so we can talk about the impact of this negative 234 on us then, and kind of have the same discussion we just had
Yes.
earlier. All right. Any other questions or concerns about the financial report?
No.
Hearing none, next item is the MedBin contract amendment.
Okay, so it's just the codification, if you will, of the renewal terms that were approved, I believe, at the April board meeting. And Cheryl Morgan did verify that the changes in the contract amendment from last year do comport with what was presented in April. So we're just asking the board to sign the contract amendment for this year based upon those terms.
Mr. Chairman, you need a motion approving you to sign that contract?
Yes, please.
I would make that motion.
Thank you. Harry, is there a second?
I'll second.
Wait, second, Paul. Any discussion? Hearing none, all in favor, please say aye.
Aye.
Any opposed? Okay, motion passes. Thank you much. I'll get those 3 pages signed and scanned back. Next item is the MedBin year-end review.
Okay, can everybody see my screen?
Yes.
Okay, you'll see that I added some numbers over to the very far right-hand side, but on this first page, we're looking at your claims dating back to 2021 and 2022, and then on the very far right-hand side, you'll have how your plan performed in 25 and 26. I added some additional numbers over to the right-hand side here because you had over $500,000 that came in the form of stop loss reimbursements after June, which is when this report was run through. So some of the numbers on this first page I edited because with over $500,000, it brings your total claims down even more. So through the end of June, you had $743,000 in stop loss reimbursements. You received an additional $575,000 in July. So that brings your total reimbursements for last plan year to about $1.3 million in claims. When I look at your total claims and then take out your stop loss reimbursements, you were right around, why isn't it coming up? Well, it's not going to work. Hold on. Okay. So you ended the plan year with your reimbursements right around $5.5 million, which was about a 10% increase from your plan year in 24 and 25. When we look at it on a per employee per year basis, again, don't focus on these numbers because you had an additional reimbursement in July. But when we factor in all of the reimbursements, you ended up right around $15,354 per employee per year, which was about a 4% increase from the prior year. And then when we add in your fixed cost to your net claims, you were about $18,000 per employee per year, which is a 1% increase from the prior year. So going back to what Lisa said, you had one really large claimant that drove a lot of your spend in the last year. Your large claimants, out of the 25 of them, made up about half of your total claim spend. But one of the individuals was over $800,000 in claims. Okay. I am going to skip this page because those numbers aren't accurate because of the additional reimbursement. But looking at this page, so just getting into some of the main cost drivers within your plan this past year, your pharmacy claims went up. You did have an increase in your enrollment with the new entities adding. So whenever you see an increase in your enrollment, you're going to see more utilization, not only on the medical side, but also on the pharmacy side. And you saw both, but you also saw your average claim costs go up. So on pharmacy claims, you're up to $121 per member per month. Our benchmark is $118, so closer to our benchmark where the prior year you were below. Inpatient claims saw an increase. You had 30 total admissions this year. 12 of them were surgical admissions, which those are your most costly type of admission. And then outpatient claims jumped up. Outpatient surgeries were up 16%, but then also anybody that has a diagnosis of cancer falls into this category because the majority of their treatments performed on an outpatient basis. And then mammograms, colonoscopy, anything like that's performed. So again, those claims went up. Your office visits went down, and so did your post-acute care. And I also want to mention that all of these numbers listed here are gross numbers, so they do not take into consideration any of the reimbursements you receive back. Any questions? Okay. Zoom in. Okay, so looking on the left-hand side of this page, this is just breaking out some of the medical trends within your plan. Again, it doesn't take into consideration any of your pharmacy claims. I'll show you this on the pharmacy side when we get to that section. But just focusing on pharmacy, you can see the increase that you saw in the number of employees that you cover, as well as the number of members. Number of members includes dependent spouses and children. So you can see the increase there. The number of people that had a claim so far this year, you can see, or I'm sorry, for all of this prior year was 746 members, which was an increase from the prior year. And then we paid and processed 11,418 claims, which is also an increase. So more members, more utilization, more claims, and the average cost of your medical claims went up from last year. And again, these are gross numbers, so doesn't take into consideration reimbursements. The prior year you were at 422, and this year you're at 500. in our we're comparing you to our municipality and public benchmark, and they're right in the middle of both of those, so at 456. Any questions? Okay. And on this page, breaking out your coverage tiers, you can see on the left-hand side, we have employee, family, employee spouse, and then employee child. Your employee spouse coverage tier on a per member per month basis is the highest, followed by employee child, and then family coverage is the least. Your employee spouse coverage tier also has the highest risk, mostly because the age of your employees and spouses are going to be higher than anybody that has family or children captured into that category. All right. Looking at your top hospital providers, you did see an increase in total facility spend this year by about $1.2 million. The different St. Elizabeth locations and Baptist locations are broken out by the tax ID number that they bill under. But St. Elizabeth is your most utilized provider. And then you had 4 individuals that went to Baptist Louisville, and you paid about $673,000 to Baptist Louisville. Pretty high cost claims that went there. Okay. And then looking at the prior year, so total facility spend, you had about $3.6 million, where last year at the same time period, you had about 2.4. Okay. And then your inpatient admissions, you had 30 total inpatient admissions. You can see the average length of stay. For your surgical admissions, they were the highest average length of stay, which is pretty typical. You did have 1 NICU admission, but it was only a 3-day inpatient stay, and it wasn't nearly as expensive as some of the NICU admissions you could experience. But breaking out your admissions, 12 of them were medical, 12 of them were surgical, 5 maternity, and then the 1 NICU. So total inpatient days, you had about 128 total inpatient days. And then outpatient imaging, you had 195 total scans. 4 of them were PET scans. PET scans are typically your most expensive outpatient imaging scan. MRIs and CTs, although the utilization is higher than our benchmark, your cost is well below our benchmark. And a lot of that is because the majority of them are being performed at St. Elizabeth. You did have some that were performed at Children's and then St. Elizabeth Fort Thomas location. For your emergency room utilization, your average ER visit was right around $3,800. If I look at the severity of your ER visits, the majority of them were falling into a very high or high category. The most common diagnosis was for a GI disorder. You did have 2 individuals that went to the emergency room more than 6 times. One of them went, I believe, 32 times. It's a male on your plan. And then you had another one that went 6 times, and a lot of those visits were for mental health. If I look at your potential avoidable ER visits compared to our benchmark, you're falling right in line with what our benchmark typically sees from an avoidable standpoint. You're at 13%, and our benchmark's just a little bit above there. So even with the 2 members that we consider frequent flyers on your plan, some of their visits were still necessary. Not all 32 of the 1 member's visits were necessary, though. Okay. And then you can see here a breakout. So previously we were reporting when it came to members utilizing the emergency room, we were just reporting on anybody that went to the emergency room more than 6 times. Now we're showing you a little bit of a deeper dive for members that are going more than 2 times. And up top, we're comparing you to our benchmark. So below our benchmark in 2 or more visits, but above in 3, 4, 5, and 6 visits. Okay. And then of the visits that we flagged as potentially avoidable, there were 24 for the entire year that we flagged as potentially avoidable. The top one that we saw was for back pain. And your potential for savings, if all of these members went to an urgent care or an office visit, was right around $63,000. If I look at last year at the same time period, you had 14 visits that we flagged as potentially avoidable, and your potential for savings last year was about $21,000. All right. Looking at your large claims, so we are looking at anybody that has over $42,500 in claims. You have 25 members that met that threshold, and their total claims made up right around $3.2 million. Everybody else on your plan outside of these 25 members was about $3.5, $3.6 million. So your large claimants made up almost half of your total spend for all of last year. As we mentioned, your top member had about $818,000 in claims. I did go down in what Lisa had mentioned. The majority of the people on this list, their prospective risk score is going down, which typically means that their risk in the 12-month time period immediately following the end of the report period, so at the end of June, it looks like their risk score is getting better, which typically means claims will also continue to go down. I've highlighted anybody here that their risk scores are going down. Out of the members that are still active, you have 17 total. If I factor into the members that are termed off your plan, you have even more. But I did highlight so you could see over on the left-hand side any members that are no longer on your plan for one reason or another. You have 2 employees that are no longer on your plan on that page. And then you have a few more down here, 2 additional employees that are no longer on your plan. So you will not see these claims moving forward unless those members elected COBRA. Any questions on your large claim report? Okay. If I look at last year, you had 22 members last year. So similar in the number of members, but your total spend last year was around $2.2 million. Okay, and then this is just a graph of all the information I went over. We also have your utilization metrics on a per 1,000 basis on this page so that you can compare to our benchmark and how you stack up against our benchmark. And then your actual metrics here, not on a per 1,000 basis. This also doesn't have a benchmark, but you can see time period to time period areas that you saw increase or decrease. One of the areas that you saw a pretty significant increase was on your ER visits. Those went up about 33%. And just a couple things that I didn't mention, but I do want to point out, mammograms. You had 85 mammograms this year and 30 colonoscopies. And then I had mentioned your outpatient surgeries went up. You had 150 total outpatient surgeries so far, or for this past year. And then you'll see in a couple pages, dialysis services. End-stage renal disease is one of your top chronic conditions, but you did have those dialysis services did go down in the number of services from last year to this year.
Hey, Brooke, on utilization, I think it's interesting to note that telehealth office visits, routine office visits via telehealth, and mental health office visits via telehealth are up like 55%, 64%, and 50% respectively. So people seem to be moving towards virtual appointments.
Yeah. Yeah, we're seeing that continue to go up, and sometimes it's in pockets. Some providers don't like to do telehealth in certain areas, but in your area, you are seeing an increase. Where we're seeing one of the biggest increase in telehealth visits are mental health. And you guys are experiencing that. Okay. All right, looking at your top chronic conditions, end-stage renal disease is one of your highest conditions. This is because your top individual, your highest claimant, also was diagnosed with end-stage renal disease. After that, you have congestive heart failure, chronic kidney disease, coronary artery disease, and then liver diseases. Okay, digging in a little bit deeper to your behavioral health claims. So we know of 154 people that have a behavioral health diagnosis, which is up about 8% from last year. Your plan paid for behavioral health, though, has gone down about 27%. You do have a lot of dependent children on your plan that have a behavioral health diagnosis. But the number of dependent children 15 to 19 actually went down just slightly. After that age range, you do have a lot of employees and spouses that have some type of behavioral health diagnosis. A lot of individuals are seeking treatment from an office visit, followed by telehealth visits. And then the majority of people have a diagnosis of mood and anxiety disorders. You have quite a few members with a diagnosis of depression, and then mental health disorders classified as other. Okay, and then one of your frequent flyers to the emergency room did have quite a few behavioral health ER visits, and you can see any ER visits listed right here. So you had 6 total that had a behavioral health diagnosis attached to it, but you didn't have any behavioral health admissions. And then just looking at your cancer dashboard, we know of 21 individuals that have a diagnosis of cancer. Their average age is right around 52. The majority of them are employee males on your plan. And what you spent on average per cancer patient this year did increase from last year by about double. The average was right around $25,000. And a lot of members are seeking treatment from St. Elizabeth on an outpatient basis. Okay. And then diabetes dashboard. Members that have a diagnosis of diabetes that we know of, 75, which is actually about 11% below where you were last year. So you saw a decrease in numbers with a diabetic diagnosis. We know of 74 of those members that are that we have medication or that we have a medical claim for, and 71 of them we have medications for. Most members have a diagnosis of type 2 diabetes. What you spent in medical claims for these members did go up this past year compared to the prior year, and it is above our benchmark. The cost that you spent on pharmacy claims went down slightly. And your top medications are Mounjaro, Ozempic, and Jardiance. Oh. Uh-oh. Okay. Looking at your living compliance, you can see on this page, this report was run on August 13th. So for your annual wellness exam, you're at a 45% compliance, cholesterol 66, colonoscopy 49, mammograms, you're at a 62, and then pap smears for members 21 through 29, you're at a 46% compliance rate, and over 30, you're at a 54%. And then just some additional information in the next section looking at your pharmacy claims. So again, your pharmacy claims did go up on a per member per month basis by about 10%. The majority of your prescriptions being filled are still generic medications. So you have an 88% generic fill rate, which is excellent. Your top 5 medications, this is a little bit hard to see, so I highlighted. You can see on the left-hand side, Mounjaro is your top medication. The cost of Mounjaro has gone up pretty significantly from last year. Last year, you had paid about $80,000, and this year, you're well above $200,000. Ozempic and Jardiance went down. So what we're seeing is members that have tried Ozempic or another type of another GLP-1 medication are switching from that medication to Mounjaro, and Mounjaro is the most expensive GLP-1. But you do have to jump through hoops before you can get to it. And then the cost of Jardiance also went down. Okay. I'm going to jump to page 3 of this report. So similar to what we looked at on the medical side, this is just your pharmacy trend, so does not include any medical claims. You saw an increase in the number of people that filled a script this year and an increase in the number of scripts that were filled. So more utilization on the pharmacy side, and then your average script cost went from $117 to $131. Okay, and then jumping to page 5 of this report, this just walks you through your top 20 medications. Up at the top, you can see the largest increase from the prior period. We had mentioned Mounjaro had a pretty big spike from last year to this year. You have 24 members that are taking Mounjaro. And then Ozempic, the cost of Ozempic went down. Last year, Ozempic was your #1 spend for prescriptions, and this year it's dropped to 2. So that went down 32%, but Mounjaro jumped up. Okay. And then diabetic therapy is your most utilized therapeutic class. From looking just at your ages for members that are getting prescriptions on a per claimant and a per script basis, your 70 plus population per claimant is the highest, as well as per script. And then the only other thing that I wanted to touch on was with our forensic claims analysis. So every night, all your claims run through. It's essentially an AI platform, just to make sure that claims are being billed appropriately for all of last year. So through the end of June, we found about $77,000 that the plan was not responsible for paying. And that is it. Any questions?
Always a blast to go over the annual report.
Sorry, that was a lot.
Any questions or concerns? All right. Hearing none, we will move on. I guess the next topic is a discussion about those weight loss drugs, those GLP-1s.
Yeah, so this subject is on the agenda at the request of Harry. And we've had a lot of employers and a lot of employees asking about coverage for weight loss drugs, specifically GLP-1s. So currently your plan only covers GLP-1s for diabetes, type 2 diabetes, and somebody has to be diagnosed with type 2 diabetes and they have to meet certain other criteria before they can get the GLP-1. So the GLP-1s for diabetes are the ones that Brooke was talking a lot about, primarily Ozempic and Mounjaro. There are weight loss equivalents for those two medications. The weight loss equivalent for Ozempic is called Wegovy, and the weight loss equivalent of Mounjaro is called Zepbound. So you don't cover those weight loss versions of the GLP-1s currently. And most other employer plans do not. Nationally, about 20% of employer plans cover the weight loss versions of the GLP-1s. And what the evidence is showing so far is that that has increased plan cost by anywhere between 5 and 14% for those employers who cover the drugs. So for your plan, that would equate to between $56,000 and about $146,000. So they're expensive drugs. They are about $1,200 a month on average, up to $1,400 a month. And when you consider that 2 out of every 3 American adults are considered overweight or obese, that would be a lot of potential expense that would come onto the plan. Now, the question is, yes, they're expensive drugs, but are there offsetting reductions in medical claims that would justify that additional expense to the plan? And so far, there have been 3 key studies on that question. And the most recent one in 2026 showed a 3% reduction in healthcare claims for plans that covered the GLP-1s for weight loss. 2 other studies, one in 2025, showed no significant reduction in claims over a 4-year period. And the third one, which was done by the VA, and it was a study of 1.4 million people, showed that while people lost weight and had reductions in their A1C and fewer cardiovascular events, there was no significant reduction in medical claims costs. And the University of Chicago has done a study in which they have concluded that when weight loss drugs get to about $127 a month, that's when it makes sense to cover them. So we're nowhere near that right now. The drugs have come down in price and they probably will continue to. There are a lot of newer drugs in the pipeline. So as newer weight loss drugs come on the market, the older ones are going to reduce in cost. But right now, the science just doesn't support adding that cost onto the plan. Now, if you really, really want to cover the weight loss drugs at this point in time, there are ways you can do that mitigate the cost. The first one, and we've had some employers decide to do this, not many. So we don't know what the end result is going to be to their plan cost yet because they just started this year. But you can implement some pretty strict clinical criteria for covering the weight loss drugs. So it wouldn't be anybody who's, somewhat overweight and wants to lose a few pounds. It would be somebody who's got a really high BMI and probably some other comorbidities. And you can also require members to participate in some kind of lifestyle management program in order to get the medications so that they are actually making changes in their behavior that will enable them to keep the weight off after they discontinue the drugs, because you're not supposed to stay on them forever. There are risks associated with the medications. So you don't want somebody just staying on it for forever or coming off of the drug and then gaining all the weight back, which is what typically happens unless there's some kind of meaningful behavior change. So those are two things you can do. The third thing is, we've had one employer go this route. Instead of covering the drugs on the health plan per se, you can implement a health reimbursement arrangement and reimburse members for purchasing the weight loss drugs on their own. So here's the thing. The drugs cost a lot less when consumers purchase them directly from the manufacturer. Or in the case of Wegovy, consumers can purchase them through Costco. They're under $400, depending on the strength and which drug you're on. So if you, as a group or as individual employers wanted to offer some coverage for weight loss drugs, you could say, okay, employees, we'll reimburse you up to, whatever. The employer that we had go this route made it $400 a month. So the only downside to that is they have to pay the money out of their pocket and then get reimbursed. But $400 a month is a lot, less than $1,200 a month. So that's kind of the background and some of the alternatives that are available, and happy to answer any questions and listen to any discussion you guys might want to have about that.
Lisa, the last part that you had just mentioned, so it would just be topped out at a certain dollar amount. Again, that would be on a reimbursement basis as opposed to us, the plan paying upfront. The individual would go to the pharmacy, they would pay it, I guess, just out of pocket, and then submit forms and things, and
Yes.
they wouldn't have to have a very specific or I guess diagnosis. That would, again, they would talk with their doctor, they would get that drug prescribed, and then the
Well,
amount would just
they
be
would have to have a letter from their physician stating that the drug was medically necessary for them in order to have that medication be reimbursable per the IRS.
okay.
Yeah.
Okay. And is that $400 mark? I guess I know that a lot is put into amounts. Is $400 just the going rate, or was that specific to that group? Did they just decide to reimburse $400, or does that sound like a lot, or would you suggest less, or how would that go?
I mean, I think they wanted to set it at a level where it would cover whichever avenue the member wanted to take. I think that Zepbound, the weight loss version of Mounjaro, which is the weight loss drug of choice for most people, is obtainable depending on your dosing and so forth through Eli Lilly Direct at about, I think it's right about $350 now.
Okay.
I did that actually. I got Zepbound right from Eli Lilly. It was $400.
It's $400 right now.
Yeah, it was this was last year, but yeah.
Oh, okay.
Yes.
Okay.
And it was a coupon, but I had a prescription from my doctor, and then you get it right from them. And yeah, it was
Okay.
a lot less than that was what she recommended that I do it that way.
Yeah, thanks, Linda.
I guess my thought on this is that I think we should probably try and do something. I mean, we had one person with end-stage renal that was $800,000 in claims. And as the obese population gets older, I think we're going to see more end-stage renal, which is extremely expensive. So, you know, and that's just one, like you said, there's cardiac. I know they've done studies that says there aren't really savings, but I mean, if we could make sure that somebody had to be a certain BMI or a certain obesity or something like that, so it just wasn't people who wanted to lose 10 pounds. You know, I just can't imagine that at some point you wouldn't see ROI on that.
Yeah, I brought this up because, Medicare is starting to cover some of those. And, I know of members that aren't necessarily in poor health, but they're obese and they've got some other comorbidities going on, but they have not been diagnosed as diabetic. So this medication is unavailable to them, and it's extremely expensive for them to be able to purchase. So that's kind of why I wanted to look into this and see what we could do to potentially help with their overall health and kind of save the plan in the long run.
So Lisa, if we made this reimbursement program that you spoke of, would it just be very specific, like 2 different drugs? Or would you're saying this would be for weight loss only drugs, as opposed to like this being part of the Manjaro or those other, but you're saying those other drugs are specifically for I guess diabetic issues, and this would be just a weight loss only.
Yes, drugs for weight loss. And really what you're going to see is people want Manjaro and Ozempic, but mostly Manjaro.
So I guess so, would anyone that's currently on the Manjaro that's hitting the plan, would that?
Oh, I'm sorry. I meant to say it would be Zepbound. They're the same
I'm sorry.
drug, just different names. One is labeled for diabetes, which your plan does cover if someone is a diabetic and meets other clinical criteria. The HRA would be covering the weight loss version of that drug, which is Zepbound.
And would it be very specific, like I guess 2 different drugs, or is there, would it matter?
I don't think it really matters, as long as they're being prescribed something for weight loss, and then the physician has indicated that it's medically necessary for them. And you could put more specific clinical criteria on there and have the physician attest that the person meets those criteria.
And if we covered this, would that, because I know our plan doesn't cover other weight loss, I guess, medical procedures and things, would this open up to where we would have to cover that, or could we specifically say we're just going to cover these drugs for weight loss up to a certain amount, and or would that open us up to have to cover other stuff?
No, you could limit it to the drugs.
Okay.
Well, next question on that same line. In order to make lifestyle changes and continue to stay healthier, do we then look at some sort of dietitian or nutrition help?
That was
go ahead.
Sorry, Lisa. That's the other thing I was going to say. Not on this plan, but on a former plan that I was on, I was able to get onto Berry. I think that's what it's called, Berry. And they just took I paid nothing, and I had a weekly call with a nutritionist. And it's covered by a lot of insurance companies. And it's just an app, really, but I think it was a lot less expensive than going and meeting somebody in a doctor's office and getting a nutritionist and stuff like that. So I don't know if I did that with this, I don't know if it would be covered or not, but that's really good education to get out to people, I think.
Yeah, it probably wouldn't be covered right now, but there are programs like that. And I'm not familiar with that one specifically. We could certainly see if it's something that the plan could adopt. There are other programs we're aware of. Teladoc has a weight management program. You don't currently have Teladoc, but that's something you can get through MedBen. There's a company called Hero that we've had discussions with. We haven't had any employers implement that program so far, but it is the same kind of program that Linda's referring to, where they help you find ways to make lifestyle changes and manage your weight. And they also incorporate the drugs, which the plan pays for, of course, but there are different options available in that regard if you wanted to add something like that and required that somebody participate in one of those programs in order to get the drugs through either the plan or an HRA.
Lisa, you mentioned that there were some other plans that had done this. Is there a track record with that, or is it relatively new? Have you seen, is there been success with this, or, at least do they know kind of what the cost has been up to this point?
Well, and Cheryl Morgan's block of business, the employers who are doing weight loss drugs have just started doing so really don't have any results to share with you now. MedBen has had groups who have covered weight loss drugs. Brooke, do you want to speak to their experience?
We have groups that cover weight loss medications and just on their plan, and their claims are just being blown out of the water. They're trying to figure out a way to not cover them now. Groups, but we do have more groups that aren't currently covering them that have looked into doing, like as Lisa mentioned, funding an account up to a certain amount to reimburse them if they want to get on the medications directly from the consumer or directly from the manufacturer.
Lisa, a couple of years ago at one of the health innovation conference sessions, there was I guess a pharmacist who had mentioned that there were older weight loss drugs that predated GLP-1s that were like 85% as effective and like a tenth of the cost. Is there a way to kind of incorporate those into something along those lines with HRA and limit to them, or because I know it's going to be really hard to fight commercials. I mean, the marketing is going to be there for the GLP-1s, but if we offer maybe a different option and say, okay, if you choose this one, this would be 100% covered by the HRA, but if you want a GLP-1, it's not going to be all the way covered by a HRA.
Yeah, we can look at that. We probably won't have many takers, but because they all want the GLP-1s, but it's something anyway. There's a drug that Brooke, do you remember the name of that drug? That it's like
yeah, give me 1 second.
We can ask our pharmacy consultant for recommendations on that and bring them back to you for the next meeting.
So the medications that are effective for weight loss but aren't a GLP-1 are phetermine and topramate. You take those together, and then Qsymia.
That's the one I was thinking of.
And then another one that people used to be on, and that some doctors are still prescribing because it's a pill and not an injection, is Adipex. But those have just that they're just not popular anymore because the GLP-1s are available. And that's what most people are on.
Yeah, I
Brooke,
also GLP-1s
so-
have a quicker result rate. Like you see the results a lot faster with them than you would with the older meds.
Brooke, you indicated that there's other plans that their budgets were kind of getting blown out of the water from this. Did they have a set amount like that $400, or were they paying a percentage, or were they paying 100% of, let's say if it was Monjaro, they were paying 100% of that cost, or were they just high cost drugs, or what was
So
it
it
situation?
just weight loss drugs just in general were covered under their plan. So it falls into whatever category or whatever copay design those weight loss medications would fall into. They didn't have a cap. They've been covered under their plan for a long time, but not until a couple years ago did people really start understanding and realizing that they were being covered. So
Okay.
yeah, they're just covered under their traditional plan design. And so not only do they have this increase that you're seeing right now on GLP-1s, but they're also seeing the increase and spike in members that are taking those same medications but for weight loss. So they're seeing the Ozempic and the Mounjaros for their type 2 diabetics, but then they're seeing the Zepbounds and the Wegovy's on their plan as well.
And they're seeing it to that $1,200 a month as opposed to them buying it on an individual basis and being reimbursed. So it's probably 3 or 4 times the cost
Exactly, because say that they're responsible, or say that their medications, I don't know what tier those medications fall into, but I think their highest copay is like $100. So members are paying $100 to get this medication versus, if they were going to like a Medispa, getting it through the manufacturer, and it's going to be $400.
Okay.
So
They've actually said that it's been a good recruiting tool.
So, great discussion so far. Just to try and move things along, Harry, would it be appropriate for the board to ask MedBin and Cheryl Morgan to put together some recommendations and bring that back to us by the end of the year? That we try to consider that into our next plan.
Yeah, I would request that. That way we can just take a look at it and weigh our options.
Great. Everybody okay with that?
Yes.
All right. Great. All right. Any other questions or comments on this? All right. Next item on the agenda is the Rescribe program update.
Okay, so in the materials, there were a few Rescribe flyers, and these are revised flyers from when we rolled the program out. I think we did that mid-year last year. So what we have found across the board with all of our clients who are doing Rescribe is that a lot of employees and other members are very suspicious of anybody asking for information about their personal health or just being approached by a company that they're not familiar with. So we are going to recommend pushing these flyers out to your members, and also Rescribe is going to be doing some other outreach. They're going to go back and try to contact people who they tried to contact initially who did not respond. And we're going to try to make it clear that Rescribe is a partner of your plan, because you almost won't believe me when I tell you that the amount of savings that was left on the table so far was $318,000. So there are a lot of savings that we could be getting if people were willing to participate with Rescribe. It's a completely voluntary program. But it benefits the employees, because if they're willing to work with Rescribe, they get their medication at no cost and it gets delivered to them at their home. So it's a win for them and a win for the plan. So we really want to do some education and make sure that everybody's aware that Rescribe is legit and that if they want to participate, it's probably a really good deal for them.
Lisa, when you say $318,000, is that just for our plan, or is that like total, like the individuals would have saved part of that too, or is that would that have, that 318, would that wipe out our debt, so to speak, for this past year if everyone would have participated in that?
Yeah, plan savings.
Yeah.
Okay. So this is a major
Major.
education,
Yeah,
but it's all about education, correct? I mean,
yes.
just so we're clear, the individual, they're going to get the exact same drug. It's
Mhm.
gonna be delivered to their home. It's going to be zero cost to them. There won't be no effect as far as that goes, correct? It's same
Correct. Same drug
prescription,
just
same
comes
dosage.
from Canada.
Okay. Well,
So we really need your guys' help on this. Make sure everybody's aware who Rescribe is. And Brooke, can you talk about some of the other initiatives that Rescribe is going to be undertaking in the next few months?
Yeah, so we had a meeting with them last week just to discuss ideas and how we can get members to participate. Because it is voluntary, you're not allowed to make members do this program. So they're going to work on reaching back out to members that they reached out to initially, just to see if they could get them engaged that way. We're making our letters more detailed and letting them know that this isn't a scam. And then they're also going to work by the end of the year to start sending out text messages to members and trying to engage them that way. So we're all working together to figure out a better way to get members engaged with this program, because of our groups that do have really good engagement, the difference that we're seeing is just the education piece, just letting members know that it's not a scam. And I don't blame them. You have so many people calling you, texting you, reaching out to you, letters that you probably don't read. So we're going to try a few different avenues to get that engagement up.
Great. Any other questions or comments about Rescribe? Great. Next is just general announcements and reminders.
We have our conference coming up, and that is September 17th and 18th. Everybody should have received email invitations. So if you haven't already registered, please do. You can register on our website, or you can just let me know or any Share Morgan staff that you want to attend. It's a day and a half conference, but you're welcome to come for any part of it that you're able to come for. And we've got some fun social events, including a trip to the Sign Museum. If you haven't been to the Sign Museum before, now's your chance. So you're all welcome, and we'd love to see you.
Yeah, Sign Museum's a neat place.
Greg, I just like to, I know last time I was at the meeting, it was supposed to be my last meeting, there was a hiccup. But anyway, this is my last meeting, and I want y'all to meet Keisha Smith. She's going to be taking over as treasurer October 1st, and she will be the new board member.
Hi, Keisha. Well, welcome aboard, and Peggy,
welcome.
we'll say it. Thank you so much for all the work you've done with us and serving on the board. It's been wonderful, and you've been a key piece, and we appreciate it.
Okay, thank you all.
thank you, Peggy.
For those of you on the appeal committee, 1 o'clock at the ad, we'll get those put away. And our next meeting is when?
October 16th, 9 a.m. online.
16th. Right. Anything else for the good of the order? Hearing none, I'll entertain a motion to adjourn, and I want to thank everybody for attending. Really appreciate it.
So moved.
Harry?
I'll second.
Right, second Terry. All in favor say aye. Aye.
Aye.
Right. See you all in September or in
Have a
October.
great weekend.
Thanks, everybody.
Thank you.
Thank you. Bye.